worsen the class 2. Okay. Side effects of class 2 elastics. It can cause excessive lower incisor proclination. How can you control lower incisor proclination? This is my lower incisor. It's getting proclined. How do I reduce this? I need to bring this back. For me to bring this back, where should this go? Forward. So if I use a bracket which pushes the roots forward, the proclination can be reduced. Which way is this root going? Labially. So what bracket do you want for the class 2 elastics on a lower bracket? LA. Okay. So LA bracket. So what do you do if you have an MBT? In MBT, you have something called a high torque and a low torque brackets. The high torque brackets of MBT are similar to LI. Low torque brackets of MBT are similar to LA. You get them here? High torque and low torque? Yes? That's it, then you know what to buy. Whenever you use class 2 elastics, you need to have an LA bracket at the lower that can prevent the lower incisor from proclining. In POS, we have LA or SLA. SLA is, what's the difference of LA and SLA? Super label top means the bracket slot is reduced to O20. Some patients may have TMJ discomfort. Soft tissue irritation also is a big problem with class 2 elastics. Some more kids will complain it's creating some soreness on the cheeks because it's constant application to that. Okay, so that's how you do class 2 elastic for brackets. To summarize, class 2 elastics and brackets can correct 1 to 3 millimeters of class 2. It has effect only on the lower anteriors because it cannot dislodge the upper anteriors. Lower anteriors come forward to correct class 2. So you have to check for tissue thickness, you have to check for lower incisor inclination and start. As it comes forward, you want to prevent the upper incisor from retroclining, so you need to use an LI bracket in the upper. You want to prevent the lower incisor proclination, so you choose an LA in the lower. Okay? In addition to that, the lower molars, when I apply force for the lower molar, the lower sixes to the upper keyhole, the lower molar comes forward, isn't it? That's your desired movement. But because I'm applying the force from the buccal surface, you also have another vector which can rotate the lower molar lingually, isn't it? This is my lingual surface, this is the buccal surface. If you pull me from here, I can come forward and turn this side. So the mesiolingual rotation of the molar is another side effect of class 2 elastics. Alright? So what do you do to prevent that? You use a special band called the C2E band. C2E stands for class 2 elastics. What does this band do? Just look up. It's the same rod band, but the buccal tube is welded more distally. Sorry, more mesially. Okay? More mesially. So when I align the molar first, during alignment, the tooth turns distobuccal. It's a compensation for what is going to happen in mechanics. During alignment, I turn the tooth like this. Now when I apply class 2 elastics, the tooth comes forward and becomes straight. A compensation that is done for usage of class 2 elastics by welding the buccal tube more mesially is called a class 2 elastic band. The same rod band on the buccal tube is welded at a different position. Okay? The class 2 elastic principles of aligners. Also, maybe we'll connect 1 to 3 millimeters of class 2. It requires patient compliance because the patient now has to do two things. They have to wear aligners first, then elastics. remove elastics, remove aligners. You need to do this every time they eat. Okay? Some of these patients are complaining of weight loss when they go through aligners. Why is there a weight loss? Because they're lazy to remove the aligners, eat, and then wear the aligners back. They just feel like not eating at all. So the mothers complain the kids are losing weight, not because of therapy, because they're lazy. Okay? I'm telling you all of this because I've seen it happening. So this elastics can only cause mentoalveolar movement of the lower teeth. Okay? This has the ability to also distalize the upper arch because aligners work by push mechanics. Okay? Buttons may debond frequently from the teeth, and that's how, if you use that mold we just discussed, that's how your button will look, like you see it on the canine. Between composite buttons and metal buttons, which one would you prefer? Metal, because composites will break. Metal will not break, it's as good as a bracket. So what I do is, what you see in this picture. For the aesthetic zone, I would use a composite button. But for the molars, which are not visible, I would still prefer to use a metal button. Because for you to achieve isolation in that area is very difficult. It's very frustrating when you give it to them, they come back the next day, it's broken, it's broken, it's broken. 2 or 3 times you do that, then they stop wearing aligners because they get frustrated. So prevent all of this. Also a little small tip. When you do these buttons for the molars, after you bond the button, before you cure it, take a thin flowable composite and go around the button and then you cure it. The flowable composite acts as an additional retention which can prevent the buttons from debonding. Okay? Try it. Clinical tips. Because you don't want that guy to come out. If it comes out, the therapy will not work. Okay? And the same thing applies to your molar buccal tubes. When you use molar buccal tubes, I slightly roughen the enamel with a burr, etch it, take my buccal tube, position it, adjust to where it's best. Before I can cure it, I take a flowable composite and I go around it. Don't put too much. Just don't go fill the buccal tube. Thin one at the junction of the buccal tube and the teeth for additional retention. And you will see that the buccal tubes do not debond so easily. Okay? End mass, lower advancement. And this will be like, this is what the video is showing you how it jumps, illustration of jumping. This is what a setup will show you, okay? Do you see a jump in the end? It's telling you if you use the elastics as prescribed, you will finish in that position, but that position will not be shown in your initial setups. Okay? It's shown only in the end. This is what you should expect to see. This is called unrealistic jump. If you tell the aligner company, please finish, when you fill the aligner slip, it asks you what should be the molar relationship when you finish. If you tell them I want it to be class 1, they will make it class 1, but it's not going to happen clinically. So if you look at this video, it's aligning teeth, 8 millimeters class 2, class 1. Do you think that can happen? No. When can that happen? Mandibular advancement surgery. And that's exactly what happens in mandibular advancement surgery. You just align teeth, give it to the surgeon jumps it, and it shows this when you finish. Okay? Visualization of posteriors. This is what happens when you do class 2 elastics. Okay? That's your button cutout. The button has to go here. This is called sequential mesialization. You see 4 goes forward, 5 goes forward, and the aligner material sort of fills in between the places. But you need elastics for that to happen. In this video, first the teeth have to straighten first, then it moves forward. What does an aligner need for it to work? Patient got it. Huh? Big size, okay, I agree. It needs space. Unlike braces, aligners will work better only when you have space between the teeth. That's the reason why they give you IPR in the beginning to create the space. Okay? If you don't have space, it's not going to work. What will a class 2 elastic do when you apply the force? It will move the teeth and close the space. Correct? So this is the thing that you should write it down. When you have a class, just hear me out first. When you have a class 2 elastics used on a case that has rotations, start class 2 elastics after the rotation is corrected. Because if you use class 2 elastic before that, for rotation correction you need space. And class 2 elastic is now going to close the space. So you can't start elastics before the teeth are aligned. Okay? So when the teeth are getting aligned, wait. Once the teeth are adequately aligned, now you can use your class 2 elastics. Which is why they don't give it to you on the first aligner, they give it to you somewhere in between. In your setup, when you see it, it will show you all these stages. Suddenly in one stage, you will see a cutout. The stage at which you see the cutout is when your class 2 elastics have to be started. Okay? Write it down. Class 2 elastics has to be started when rotations are almost corrected, because otherwise it will take away the space that is needed to correct the rotation. Aligners work when you have time plus the space. As you work 22 hours a day, and you should need to have space. Okay? That's the mold we spoke about. Use this mold. And when you have another opportunity to engage the elastics. That's what you see in Invisalign. Is you have something called a precision cutout. Precision cutout is a small cut that is made on the aligner material, and you can engage the elastic on that cut. That's called a precision cut. What's the disadvantage of that?
The plastic.
Huh?
Distortion of the plastic.
Distortion of plastic during application, because plastic is now pulled away from the tooth, and this plastic has to completely embrace the tooth for it to show its effect. So button cutout is a better option than applying on the precision cuts. Okay. That's your option. Either you have button cutouts or elastic hooks, cuts. This weakens the plastic because you cut it. This one pulls the plastic away from the teeth. Okay? Anesthetic bonding on the canine. Some people who don't accept the cutout, the button, composite buttons also, then for them you have to use an elastic cutout. Pull the aligner away so that then it doesn't embrace the teeth so well. Okay, this is very, very important. Is you have to, first thing you have to do in a class 2 correction with molars is to rotate the molar mesiobuccally. That's called mesial out. Okay. If you see the molar classification and you see the molars are class 2, if you look at the same molar lingually, there's something called lingual molar classification. Lingual molar classification is in the mesiolingual cusp of the upper 6 occludes with the central fossa of the lower 6. That's called lingual class 1. And very, very commonly, you will have lingual class 1 and buccal class 2. That is because the upper sixes will rotate mesiolingually all the time. Why does it happen? Because when the upper is shed and the sixes come forward, the palatal root of the upper six is long. So that does not move forward. Hence the upper six rotates around the axis of the palatal root. So lingually it stays where it is. Buccally goes forward after the E is shed. Can you picturize that? So first thing you have to do is, when you have class 2, turn around, look at the lingual relationship. The lingual is class 1, which is the mediolingual crest is on central fossa. It's a very easy case. Just derotate the tooth and the molar will become class 1. Okay? That's what this picture is telling you. So as an aligner setup, every aligner company, if you're working with them, you must tell them, please rotate the molars mesiobuccally so that the molar can become class 1. Okay? The biomechanics of brackets versus aligners. Clear aligner distalization is possible with class 2 elastics or skeletal anchorage. If you want to use the brackets, you need skeletal anchorage. Aligners with elastics, you can push the molars back. Okay? And mainly in growing patients, skeletal effect is aligners will not do anything, but it uncouples the occlusion. It uncouples the occlusion. It allows the differential horizontal growth, which is the growth of mandible more than the maxilla, to express, like your functional appliance, disoccludes teeth. The brackets, if you use it at the right time, it can restrict the maxillary growth. That's the class 2 biomechanics of the difference between brackets and aligners. Okay? When to start elastic with aligners? This is what I told you. When distalizing the meal, whenever you have rotations corrected, you can start immediately. When you have a lot of rotations, wait until the rotations are corrected, because for the rotations to get corrected, you need space. And if you use elastics earlier, you will lose space. The elastics that is used with aligners are called giant panda. That's another animal. So the force it applies is 4.5 ounce, and the size of the elastic is 5 by 16 inches. Okay, 5 by 16 is a much more larger elastics. It's called giant panda. It's considered to be ideal for the effect of elastics on aligners. What do you do when the buttons come out during your elastics? There's a method to put them back. How do you put them back? Take it out, clean it, burn it with a cigarette lighter. Burn the composite on the fitting surface with a cigarette lighter until it becomes red hot. Wash it, now sandblast it. This bracket will now have a completely clean mesh for you to bond it back onto the tooth. If you haven't cleaned the button adequately and you use the same button backing, it will come on again. So your preparation of the button is very important before you fix it back. Okay? So take it out, wash it, burn it, sandblast it, and put it back. When you put it back, avoid touching the button with a finger, bare finger. You should use only a gloved finger. If you use a bare finger, you have some oils and your moisturizing cream and all your hand creams on your hand. That can weaken the bond. Okay? So typically your nurse is actually loading and giving it to you. So you should tell her to use only a gloved finger for that. Do not put it back. When you put it back, then you have to prepare the teeth. You have to take a finishing burr, clean up the enamel where the button is bonded, again etch it, dry it. You should see what? Frosted surface. If you're using a metal button, you'll apply a primer, don't cure it. If you're using a composite button, you'll apply a bonding agent, cure it, and then put the composite button. how you rebond. Because rebonding buttons is very, very common, very frustrating, typically because of the position. Okay, if it's more gingival, you have this gingival clavicular fluid, the GCF, which can still create some amount of contamination, and that creates a frequent debond. There is something called cutout pliers. Cutout pliers, if you take the plier and make a cut on your plastic to make the cutout bigger than what the aligner company gives it to you. It's available in POS as well. I'm sure it's available here also locally. If you think they've given you a button very, very gingival and it's frequently getting debond, you can use the cutout plier and make the cutout a little more bigger and come up a little more occlusally and then bond the button so it doesn't get frequently debonded. Okay? Let's look at the case. Any questions? Are you guys confident to correct class 2 with non-extraction? You had a question?
Just on the anterior cross elastic, is like you take the lower mandible, go to the correct upper. What if it's the upper midline that is not correct? Then it's
The anterior cross elastics does not correct the midline. The anterior cross elastics corrects the functional shift. And the functional shift is because of the mandible. When your maxilla has got upper midline not centered, then it's a complete diagnostic issue. You should first find out why is it not centered. It can very commonly be not centered because of an asymmetry. The entire arch will be asymmetric. And you will have class 1 on one side, but class 2 on the other side because the whole arch is asymmetric. That's one of the common reasons. Second, you have crowding, like the lateral incisor is in crossbite. Central incisor is moved here and the midline is moved with it. The moment you correct the crowding, the midlines will get centered. So you should look at what the problem is. If you see the occlusal view of your upper arch, you should be able to see that 1/6 and 2/6 are at the same level. That means their case does not have an upper dental asymmetry. If your case is showing 1/6 is here, the 2/6 is here, this is an asymmetric arch. No matter what you do, the midlines will not get corrected unless you extract something. For you to correct the upper dental asymmetry because of mismatched molars, you have to extract something and make it symmetric again. Do you understand that? What will you extract? If your arch is an asymmetric arch, you're allowed to do an asymmetric extraction. Asymmetric extraction is extraction 4 on one side and 5 on the other side. Okay? Asymmetric extraction is done to create symmetry. In other words, do not do asymmetric extraction unless you have an asymmetry. You cannot do asymmetric extraction in a symmetric arch because you will create an asymmetry. Sometimes you're very tempted. The 4 is root canal treated, the 5 looks good. Or the 5 is root canal treated, the 4 looks good. And I think, why should I extract the good tooth? Let me just extract the root canal treated tooth. You'll be extracting 4 on one side and 5 on the other side. That's called asymmetric extraction. This can cause asymmetry. That should not be done. Okay? Anything else? Any other questions? Yes.
But as you say, asymmetric arch, we can do asymmetric extraction.
Yes.
If let's say the other side is already class 1,
Yes.
the other side is class 2, can we just extract one
No.
premolar?
No. That's a very good question that you asked me. The number of premolars should be same on right versus left. You cannot have one premolar on one side and 2 premolars on the other side. That means you're creating asymmetry. Because if you extract the premolar on one side, what will be the molar relationship when you finish? On that side, class 2. What will the molar relationship on the other side? Class 1. So now you have an asymmetry. Right? It should either be class 2 on both sides or class 1 on both sides. So what do you do in that case? Where you have 4 millimeters class 2 here, and you want to extract this premolar 4 to make it class 1. On the other side, you have to extract a 5.
Okay. But what if, like, what's the side effect which is
Sorry?
what's the side effect of one side class 2
what's the side effect of finishing with asymmetry? Is that your arches will not be very well coordinated, okay? And medico-legally, if your patient develops TMD, you will be blamed. Because asymmetry is a very common cause of TMD. So if you finish with TMD and your patient develops asymmetry, then you will be blamed. Okay, so I'm not saying that people never do it, okay? But you try your best to avoid it. So I had a patient who had a missing lateral incisor. Okay, just picture the situation. One lateral incisor is missing, and there's no space present in the arch. This side the molar is class 2, this side is class 1. Everything is aligned. With that patient, just because in my mind I want to get symmetry, I'm not going to go extract. This patient is now having a very good occlusion with asymmetry. So then I will be okay with finishing asymmetry. But I need to have a discussion with the patient saying this is what ideally is supposed to be done. But if I do this to you, we're unnecessarily extracting. But I want you to know that we're choosing a non-ideal treatment decision. Okay? But if you have the case like you're saying, class 2 on this side and class 1 on this side, don't extract only on one side.
Even the midline shift.
If you have class 2 on this side, then the midline will be shifted on the opposite side. So if you extract here to bring it center, so this will be 4 and that will be a 5. If you extract 5 on the other side, it will not affect the midline. 4 on this side will create space to correct the midline. 5 on the other side will allow you to finish molar class 2. So you finish both sides molar class 2 and canine class 1. It's a very common problem. What you're saying is extremely common. Like midlines are not centered, and one side will be class 2. And you'll be tempted, let me just extract this one premolar from this side, I'll fix the midline and correct the class 2. But you will have a lot of difficulty to get the team together. Why am I saying it? You have done it. And I've had the difficulty. It's going to protect you. Not to tell you, you don't do this, so you don't have this problem. Okay? These are good questions. See, these questions are coming to your mind because you're probably doing cases. So I'm saying if you do these kind of cases, then something, as we discuss about a few things, some patient shows up in your mind, yeah, he had this, and how did we work on this patient there, and you start applying. Okay? Any other question? All good? All right. So let's work on a case. I think good. We have been talking since morning. It's good if you do some work so you can be more connected. If you take up your Medit, let me just check if you have this case on your Medit. You need to log into Derek's account.